Hi everyone, and welcome to a special OnCoffee CancerWorld episode. I'm Vahe, and today I'm joined by Professor Arjun K. Ghosh, Consultant Cardiologist at Bart Heart Centre and University College London. He's the first consultant in the UK appointed specifically in cardio-oncology, and he helped build and grow the service at BHS and UCLH that care for the heart of people with cancer. Professor Ghosh, I'm honored to have you as a host, and it's really nice to have you here.
Thank you so much, Vahe. Very honored to be here with you. I follow the OncoDaily platform closely, and I know that there's a lot of interested people who watch the content, so really happy to be here with you today.
So before we dive in, I want to ask, how do you take your coffee? Is it a calm ritual before clinic or the quick lifeline
Yeah,
between words around?
so I've got my coffee here with me today, so definitely need to kind of keep it going. So I don't think I'm a coffee addict, but I definitely like to have my cappuccino usually just to keep me going through the day, and maybe one or two espressos as well in the middle. How about you? Coffee is part of your life a lot?
Yeah, coffee is a part of my life. I drink it in every possible situation. I have it right now because we are in on coffee.
Absolutely.
So yeah, but I think I'm addicted to coffee, and I have to work on me. So cheers.
Yeah, no, cheers to you. And I love your cup. The cup is very nice and colorful.
Thank you so much. And I noticed on your cup it's the logo of Arsenal. Are you a fan of Arsenal?
Yeah, I am. I am a fan of Arsenal. I kind of grew up near the stadium, basically. So my parents' house at the end of the street was the old Highbury Stadium. So it's kind of something that I've literally kind of grown up with, and now I go to the matches. I have a season ticket. My children go. My wife goes, and my whole family. So yeah, it's it's nice. I think to have a community connection, because I mean, literally, at the end of the street. So I still remember, as a child when, they won, one time they won a league title. So everyone was literally just went out of their houses and was dancing in the street because, it's just next to the stadium. So yeah, that's kind of one of my bits of my background, shall we say.
Yeah, let me tell you, they are playing very well this season. I don't know. I think they are the best in Europe right now. And
Yeah.
as a Real Madrid fan, that's my only reaction to the play that they're playing.
So I have to say that, it's fine to play well now, but you need to be playing well in May, in April, and then it's the important thing. Because I still remember, last season, maybe a bad memory for you. I was at the match, Arsenal 3, Real Madrid 0. But I think you have to be consistent towards the end. I think that's what they need to learn this season. And let's see what happens.
Yeah, let's hope everything will be fine. Okay, so let's go. Dr. Ghosh, your work spans cardiology and oncology. What initially led you to recognize the clinical need at this intersection and decide to focus your career here?
Yeah, I think that's of course a very interesting question, and really the genesis of how I got into cardio-oncology. I think it was at the time I was near the end of my training in cardiology, and my interest areas were heart failure and cardiac imaging. And it so happened that I heard a talk at a conference on cardio-oncology. This is a new area, and bringing cardiology and cancer together. And from the cardiac side, actually, the patients at that time, most of them were heart failure patients. I mean, that has changed dramatically now, but at that time, it was really heart failure. And of course, the imaging was integral to, diagnosing these patients and treating these patients. So given my background of the imaging and heart failure, I really felt that this was a new area in cardiology that could combine both my, skill sets, and hence why I was interested in cardio-oncology. And I think also I probably am a kind of person who gets bored easily. So the fact that this was new was interesting and exciting. And I really felt that it was unlikely that any 2 days were going to be the same, and everything was unknown. So a lot of exciting prospects, and that's probably how I got into cardio-oncology.
Yeah, that's really great. And let me tell you something. It's really hard for those people who are getting bored easily because they don't know what to do afterwards. But I think these are the people who are making the changes in the field. They are trying to find something new. They are exploring, and sometimes it leads to something good.
Yeah, I think that if you're curious and you are, wanting to think about something new, wanting to explore about new things, I agree, Vi, that could be a way to, develop new avenues, new protocols, or think about even a well-known disease in a different way. I think that, in medicine and in life in general, you need all sorts of people for it to be successful. You need people to help deliver the care. You need people to think outside the box, and it takes a combination of everyone to try and get to a successful outcome for the patient.
Yes, absolutely. Dr. Ghosh, cardio-oncology wasn't an established specialty when you entered it in UK. What did you see clinically or philosophically that others perhaps overlooked at the time?
So I think that again, it probably does come back to me as a person. I really didn't want to go down an established route. I wanted to do something different. And I think that was always the case, even when I was a medical student. So my family, many people are doctors. So grandparents on both sides, aunts, uncles, cousins, they're all doctors. And I wanted to do something different. I didn't want to just be, seeing lots of patients and being very successful in that, but I wanted actually to try and make a difference, do something which was, I felt, more meaningful on a larger scale. I mean, of course, seeing patients is extremely rewarding and extremely great for society, but I wanted to, also try and move the field forward. And hence, when I, found cardio-oncology, or cardio-oncology found me, I really felt that this was an opportunity to make a real difference and really impact on the care of cancer patients. Because at that time, and it's the case now, of course, as well, all cardiologists actually do see cancer patients. That's normal. However, they weren't being treated necessarily in an optimal way. And sometimes if they had cancer, well, your prognosis is in X months, there's no point in giving you the cardiac treatment, or, a lot of misconceptions. And I think that was probably one of the reasons that drew me to it. And as I kind of mentioned, it probably is more of my character in the sense that I, didn't want to do something that was done before. I wanted to do something new, something novel. There's also, I think, a bit of a risk-taking element there as well, because the less risky option would clearly have been to take something established, but then I felt that I would have just been one of many people doing exactly the same thing. So I did want to have, do something which was new, which was novel. So I think it was very much a high risk approach, but also a potentially high reward approach. And I do remember some, more senior doctors at the time telling me, okay, you want to do this, this is new, it may not work out, and just make sure that you are still doing some other things in cardiology, because, after a few years, this may all just fade away, and then you'll still need to have a job and do something. So just make sure you're still doing some other cardiology things. And I think that was probably, it's a difference in mindset, because the person who said that to me probably comes at it from a very, shall we say, less risk taking or risk averse type of mindset, that let's play it safe and make sure. And I think that that's fine. But I think, as you mentioned, Vi, that if you want to be the innovator, you want to do something new, that's always associated with risk. If you play it safe, then great, that's fine, but you're not really going to be thinking outside the box. And I think that's probably what again drew me into cardio-oncology.
Yes, of course. Sometimes we just have to say some people, okay, I respect your opinion, but I won't do that. I will do the opposite, and I will do what I think is right. So, and it will work. So there is no need to listen to others and don't take the risk.
Yeah, I think you have to. So I don't think you should ignore other people, because clearly, especially if they've been around, the advice is from their experience. And I don't think that, what they're saying is necessarily wrong. It's just their point of view. And you can respectfully disagree and say that, yes, thank you for the advice. But, I think that, this is something that I'm interested in. And I think that, you do need to have a passion for what you're doing, for sure. If you're going into a high risk situation, if you're not fully committed or you don't believe in the idea yourself fully, unlikely that you will be a success, because in these types of situations, there's always going to be a lot of ups, but there will be lots of downs as well, because, you're really fighting to change the system. And in the UK, and probably it's the same in many countries, the medical system is very inflexible. They don't like change. And, we've been doing it this way. Why do we have to do it a different way? Is often something you hear. So, and I think not just in medicine, in many fields, anyone who's trying to be a disruptor or change things can often, face these types of problems. So, just an example that I can give is, I still remember when we set up the clinic, the first clinic that I did at Park's Heart Center. It was just me in the clinic, and there was one patient. And then the next clinic, it was literally just me in the clinic with 0 patients. And I was kind of thinking that, okay, this is interesting. What's going to happen next? And now, of course, we've got, so we have 2 clinics a week at Bart's Heart Center. We have 3 clinics a week at UCLH. So we now have basically, 5 clinics a week, from a point where we had 0 patients in a clinic. So, you have to believe in the project, and you have to really, be dedicated. And there's, of course, a lot of hard work. And I think, you talk to anybody who's, set up something new, at the beginning, of course, it is extremely challenging, but the rewards are there, of course, at the end.
Yes, of course. If you only believe.
Yeah.
So there was a line from my favorite, one of my favorite movie series, Spider-Man. Of course, I'm paraphrasing it. It says, with great powers, with great opportunities comes a great responsibility.
Yeah.
Yeah. Dr. Ghosh, you were the first consultant in the UK appointed specifically in cardio-oncology. How do you navigate the responsibility of being the first, the weight of defining a field as you build it?
Yeah, no, I think I was quite lucky, because I had very helpful colleagues who, had started out in other areas of cardiology, and then they had moved into cardio-oncology. So they were there to kind of guide me. But even then, cardio-oncology literally had only been around for 3 years, maybe 4 years, a very, very, very brief period of time. And as you say, I was the first appointed specifically in cardio-oncology. That was my job. I was the first person for that. And it was a big challenge, because, as I mentioned, there were a number of people who thought that, this was going to be a fad, and what is cardio-oncology, and really, you got a job in that? Is that a thing? And there were all these types of questions. But I knew that, the cancer treatments that were being developed, and there are, of course, many, many molecules in development, every day, literally, there's a new drug that comes out. And while the drugs are amazing from the cancer perspective, and they've massively changed outcomes for cancer patients, unfortunately, many of these do have a toxic cardiac profile. So I didn't think that this problem of cardio-oncology was going to disappear. On the contrary, I felt that the problem may change, but that there would still be patients who would have these kind of cardiac issues. So I never felt that this was a mistake. And to be honest, I never once felt during the journey that I made the wrong decision or why did I do this? And again, that's, of course, excellent luck, good luck, because you can never predict these things. So I'm very happy that this happened. But yeah, I mean, I've had excellent colleagues that I've worked with. I've had excellent trainees that I've worked with. And I think that, coming back to the question about, how does it feel to be the first or to be a pioneer? I think that it's great, but to quote, the quote that you gave from Spider-Man, a lot of responsibility, right? Definitely a lot of responsibility. And what I feel is, not only do I have to take that forward for the patients and say, by writing guidelines and, producing protocols to say that this is the best practice, but alongside that, I feel that I have a very big responsibility to the next generation of, trainees who want to do cardio-oncology. And I run the training program, and I'm very happy that I was able to write the cardio-oncology part of the UK cardiology curriculum. So now all trainees in the UK, the cardiology trainees, they have to do cardio-oncology as part of their core cardiology training. And if they're doing heart failure training, they also have to do cardio-oncology. So that's like formally incorporated, which is a big thing. And alongside that, I'm very lucky that I also do train and mentor oncology trainees as well. So at the moment, I have an oncology final year trainee. He comes down from Nottingham. He attends my clinic. He attends the NDT meeting, and he's recently passed his cardio-oncology exams. So he's a certified, cardio-oncologist. And I think that it's great because cardio-oncology is really a combination of cardiology and oncology. So, I must not just train cardiology trainees, but also oncology trainees. So to have oncology trainees come, I think is also great. So, very privileged position to be the first, but not the last. There have been people appointed after me now, which is great. And of course, we want many more people appointed to do cardio-oncology.
Yeah, that's great. And I guess the biggest responsibility is the teaching, as you mentioned, because if you don't teach, like your work, your huge work will go in vain, because you will take it with you, and afterwards no one will know how to do it. Of course, they will start to do it again, but it will take time and is not efficient. And teaching is in the basis of development of human race, so it's really important.
Yeah, I think the word doctor comes from teacher, right? So, it's a responsibility that we have to teach the next generation. And I think that it's something I like to do in any case. I mean, I've got a master's in medical education. This was something that I was always interested in, and both teaching on a day-to-day basis and also on the more theoretical aspects of teaching as well. So, in my clinic, I will always have some visiting fellow, and we've had actually visiting fellows from many countries from across the world. We've had visiting fellows from South America, from Mexico. We've had visiting fellows from all over Europe. We've had visiting fellows from Asia, from India, from China, from Singapore, from Bahrain, Middle East. We've had many visiting fellows from Australia. And I think the most important thing is that the aim of the fellowship that I run is when they go back home, that they then set up their own cardio-oncology services. And now, all of these fellows have gone back home and they set up cardio-oncology services in Sydney, in Melbourne, in Singapore, in Mumbai, in Kolkata, in Mexico City, Portugal, in Madrid, in Salamanca, in many places all over the world. And I think that that's probably one of the most enjoyable and also one of the most entertaining parts of my job, to have the opportunity to train the next generation and just really spread awareness about cardio-oncology through the trainings all over the globe.
Yeah, that's great. Like you're doing huge international work, and I really appreciate it. Thank you for that. Dr. Ghosh, cancer care often moves at extraordinary speed. Cardiology demands precision and caution. How have you learned to reconcile these two cultures when making decisions that affect both cancer outcomes and heart failure?
Yeah, so I think it's a very relevant question, and as cardiologists, clearly, we cannot keep up with the rapid changes in the cancer side in that way because it's just too fast. And the thing to remember, of course, is we're not just dealing with one cancer. A breast oncologist just needs to know about breast cancer advances, but we deal with breast cancer, renal cancer, we deal with hematological cancers, we deal with radiation-induced problems. So it's kind of next to impossible for us to keep on top of everything. But I think that one of the main things and the maxims that I go by is that any cancer treatment can cause any cardiac problem. It's just that some problems are more common and some problems are less common. And then when we go with that basis, I think that is helpful for us just to, be aware that when a new treatment comes, we should not just be saying that, well, this is new, this cannot be the cause of any cardiac issue. We need to, take that on board and try and, help the oncologist to get to the diagnosis. So I think, that's probably the way we would approach it. And, if there's any major new treatment from the cancer side that comes in, often we are also involved from the cardiac side. So we do get awareness in that way. And probably a recent example I can give is CAR T therapy. So CAR T therapy for hematological cancers really was still trial therapy just before COVID. And then now it's a normal kind of NHS therapy. But even when it was a trial therapy, we were involved because University College London Hospital was one of the CAR T trial centers. So we were involved from a cardiac point of view at the very beginning of a new revolutionary cancer treatment. And I think that I'm quite lucky that the UCLH is Europe's largest hem-onc center. So they run many trials of many different therapies. So, for example, vaccine therapy for cancer patients. So we're often involved from the cardiac side at the very beginning. So we are in touch with a lot of the latest advances.
Yeah. Dr. Ghosh, as you mentioned, you are dealing with different type of cancer. So you are regularly consulting different type of specialists, different people. And I wouldn't invent a bicycle to realize that multidisciplinary work is at the heart of your field. In your experience, what is the single biggest barrier to true collaboration between cardiologists and oncologists, and how have you worked to disseminate it?
Yeah, I think that the first or the biggest problem is really, I wouldn't say a lack of trust, but a lack of understanding. So when we set up the cardio-oncology services, Bart's Heart Center and at UCLH, the biggest issue at the very beginning was the more senior oncologists thinking that, we were going to stop the treatment. We were going to interfere with the cancer treatment. We were going to tell them this bad thing has happened and you must stop. Whereas, the whole point of cardio-oncology is never to stop the cancer treatment unless it's an extreme situation. The whole aim of cardio-oncology is to try and get the cancer patient to complete the optimal treatment with support from our side. What used to happen before is if there was a cardiac toxicity, the oncologist would just stop the treatment and then they would put them on, second line, third line, less effective treatment. Whereas our role is to try and keep the patient having the primary, most optimal treatment, with our support. So that was the biggest problem when we started. Oncologists thinking that, I don't want to refer patients because we're going to interfere. And again, it was education. And I see this all the time because I've been involved in helping colleagues all around the world set up cardio-oncology services. And I've never once seen anywhere where the oncologists have said, yeah, this is great, please start the service. Often there is some suspicion and hesitation, but very quickly changes the other way. Like once they realize that you're there to get the patients to have the treatment and make their lives easier, they are, of course, very happy to have a cardio-oncologist on board. And I think just to make another kind of related point, Vahe, that it does depend on which country you work in, because as I mentioned, I've worked quite closely with a number of colleagues in India, and in India, actually, it's the oncologists more than the cardiologists who are driving cardio-oncology, and there it is the kind of slightly different. So the problem that they have is to find a cardiologist who's interested. And I think that, it does depend on the healthcare system. If you work in a healthcare system that is incentivized by procedures, then cardio-oncology doesn't have procedures for cardiologists. So for a cardiologist to be interested in this, they may not be so interested if, they could put some stents in or put some devices in, which is more beneficial to them. So I think that, it does depend on your local system as to the problems that you will face. But like with everything, if you keep at it and you provide a good service, usually most people will understand that, there's a big benefit to your cardio-oncology service.
Dr. Ghosh, cardio-oncology is often framed as managing side effects, but many argue it represents a deeper shift in how we view survivorship. What do you think cardio-oncology reveals about the future of cancer medicine itself?
Yes, I think that probably is, as you say, right, that's kind of maybe an old-fashioned or earlier view about just managing side effects, because cardio-oncology is very much covers the whole patient journey. So we assess patients before cancer treatment. So there's no point of no possibility of any side effects. So, we assess the cancer, what is the risk from the cardiac perspective of the proposed cancer treatment. So is the patient low risk of developing cardiac problems during cancer treatment? Are they medium risk? Are they high risk? We, of course, monitor the patient during treatment. And again, there may not be any cardiotoxicity, but we monitor them closely to try and prevent that. We then, of course, can treat the toxicity, which is probably, as you were referring to, what used to be the main bulk of the work. But again, as you suggested, there is a late effects angle. So at the moment, I'm in the process with colleagues of writing a national UK late effects guideline, which really looks at how we can help manage the long-term potential toxicities of the cancer survivors. So cardio-oncology is really the journey before treatment, during treatment, and after treatment. So it's a very holistic coverage of the patient.
Thank you for clarifying that, because lots of people, also doctors, oncologists, does not really know what does it mean. Cardio-oncology, they think like you're just managing the side effects and that's it. So, okay, thank you for clarifying that. So, Dr. Ghosh, immunotherapy, targeted therapy, combination regimes are rewriting oncology. What do you believe the oncology community still underestimates about the cardiovascular risks of these treatments?
So I think that it's like with any new treatment. You sometimes need to understand what the potential toxicities are, what the problems are, and this is not something that is always immediately apparent. A lot of the treatments, the toxicities are not necessarily shown in the trials, and it's only with real world data after the patients have been on it that we see that, well, actually there is another potential toxicity, and so on and so forth. I think that it's just not just for oncologists, but also for cardiologists, just to be aware, that point that I made before, that any cancer treatment can potentially cause any cancer problem. So with a new treatment, immunotherapy, targeted therapies, if there is a signal of a cardiac issue, is it related to the new therapy? That's something that you need to be aware of. And if there is, then for sure that needs to be reported by the appropriate reporting mechanisms. And then, the registry data needs to be interrogated, needs to be looked at. And you need to try and help manage that situation. And it's just similar to, as I was mentioning, when we had the new therapy, the CAR T therapy. We did a study at UCLH looking at the cardiotoxicity associated with that as a new therapy. So I think that we've talked about this, the curiosity, about remaining curious, about having an open mind to, could this be a cardiac issue? And if you think that's the case, then to definitely try and explore that, try and interrogate that, and to work with your oncology colleagues. And again, with the same goal that we don't want to stop this new treatment, but we do want to see how we can give it safely to the patients. I think that's the whole essence of cardio-oncology.
So with these fast evolving therapies, there is also the other side of the coin, the ethical tension. So I want to ask, how do we balance the ethical tension between pushing life-saving cancer treatment forward and ensuring we are not creating a generation of patients living with preventable cardiac disease?
Yeah, so I think that's it's quite an emotional question as well, because patients obviously, at the end of the day, they need to make the decision. We can guide them as cardiologists, as oncologists, as healthcare professionals that these are the options, but the patient needs to decide whether they want to go ahead and have that treatment or not. And I think that once they are explained the risks, patients, I genuinely have to say we have two types of patients. We have some patients who will say, look, I am happy to take the risk because I want to live, which is a very understandable response. We also have a group of patients who are probably older patients who are, happy with what they have done in their lives, and they don't want to necessarily take a very high risk treatment, which will only prolong their life for a very short period of time. I think, the job from the cardio-oncology side is really, as I said, help with the informed consent. And then if the patient genuinely feels that this is what they wish to do, as in go ahead with the treatment, then we help to minimize that side effect profile of the toxicity. Now, from the cardio-oncology angle, at the end of the day, we are not oncologists. We are not experts in cancer. We are not experts in cancer treatment. We're not experts in the cancer prognosis. So that very much is a final decision between the oncologist and the patient, not with us. But our role, of course, is to help the patient and the oncologist understand the cardiac implications. But the ultimate decision does rest with, of course, the patient and with the oncologist. But the way we improve the communication is by the multidisciplinary team meetings. So if there are complex patients, and a lot of the cancer patients are complex because the evidence base is growing, so there isn't a definite easy way to say the guideline says this. A lot of patients are in a gray area where there is no definite evidence or guideline to explain what should be done. And we discuss these patients with the oncologist in the multidisciplinary team meeting. And in that meeting, we have a number of cardiologists from covering all aspects of cardiology. So imaging cardiologists, interventional cardiologists, electrophysiologists. We have our cardio-oncology nurses, we have the oncologists. We basically try and give a holistic view as to what may be the best options in the patient. So I think that multidisciplinary approach is extremely valuable in this context.
That's really important, and the information that you are giving the patient, and then he or she decides if they want the treatment or not, or not the treatment, but which treatments they would like to get. So it's really important, and the patient needs to be informed thoroughly so they make the best decision for them, for themselves. Dr. Ghosh, if you could redesign the global cancer journey with unlimited resources, what would an ideal, fully integrated cardio-oncology model look like, and how far are we from achieving it?
Yeah, so I think that the biggest issue, of course, is the unlimited resource angle of things, and that really is what stops us sometimes. I think, but it's not always a bad thing, because I think that if you had unlimited resources, you may do too much, which is not necessarily required because you just have the money to do it, so we'll do it. But that's not necessarily absolutely required. But in the ideal world, what you would like to do is have very rapid access. You should be able to see the patient, the same week, which, we are very lucky at Barts and at UCH. We're very well supported by the different teams. So we are able to see the patients within a week. But, that's the ideal scenario, that as soon as somebody refers the patient, you can see them very rapidly. So there's no delays to the treatment. And the optimal service in terms of the during treatment would be to be able to carry out as much surveillance as you wish. So that means as much, as many biomarkers, as many imaging tests, echocardiography, cardiac MRI, whatever you would like to monitor the patient closely. Now, again, if you don't have the resources to do all of that, that may not necessarily be a bad thing, because you don't also want to excessively investigate a patient where it's not required that frequent monitoring, because that can make the patient anxious. The patient already has to come in for a lot of cancer treatments, cancer blood tests, other tests. You don't want to give unnecessary additional cardiac tests just because you can do it because you have the resources. But you'd of course want to have the optimal number of tests. So that would be the ideal scenario. And I think also that in the late effect side, I think that's probably the most interesting one, because if you had unlimited resources, you may say, well, I'd like to follow these patients indefinitely, because we know that a lot of the cancer treatments, anthracyclines, can cause problems for many, many years. But on the opposite side is, would you want to completely, medicalize this cured patient forever? And what about the mental effect this has on the patient, knowing that every year I have a heart scan, because any year it can cause a problem or it can find a problem. So there's a fine balance. I mean, I think that it's great if you could have the resources, and then maybe it's more about a question with the patient to say, how long do you want to be monitored? And these are the options you have. And I think the last point I'll make on this is, I was having a conversation with a patient recently, and she told me how there was a lack of psychological support that she had in this situation, in this journey. And I think that, I work in the national, health service, so there is obviously resource, limited, and not an unlimited resource setting. And I think that, this is something that is looked at for cancer patients. They do have psychological support, but clearly more would have been better for that patient. And I'm sure more will be better for many patients. I think, that non-medical angle, the workplace angle, support for being off work, the financial support in this situation, the psychological support. There's a lot of, we provide excellent medical care in the vast majority of patients, but a cancer patient has many non-medical needs as well, which maybe we are not so great at providing. So unlimited resources definitely would help with that.
So I guess the balance is the key. And as Einstein once said, if we can visualize it, we can actualize it. So I hope one day we're going to have a fully integrated cardio-oncology model that will work perfectly for the patients. And Dr. Ghosh, I can see you are doing a huge work both for UK and internationally. And I hope one day we'll reach to the point where every country, every hospital that has a cardio-oncology department and is working really hard for the patients and for their well-being, and also taking care for their heart, because heart is, if not the most important, one of the most important organs that we have. Thank you for the work. And I also want to do a blitz round, if you don't mind. Who is Professor Arjun Ghosh? I'm going to read some questions, and please answer them as fast as you can without thinking too much.
Okay.
Okay, whenever you're ready. So, a personal motto or quote you live by?
Have a strategy, but take calculated risks.
Favorite city?
So I grew up in London and Kolkata, so those are probably the two cities closest to my heart.
Favorite book and movie?
So I love 100 Years of Solitude by Gabriel Garcia Marquez. And movies, I think any movies from my childhood, things like, Star Wars, things like Indiana Jones, all those types of kind of Spielberg movies, they just feel good movies.
Great choices for both books and the movies. Best piece of advice you ever received?
So the best piece of advice I ever received, I think, was, in terms of related to cardio-oncology, somebody said to me that if you don't go to the party, you'll never get a chance to dance. And that what he meant was that unless you put yourself forward to say that, yes, you want to do this, you want to take this risk, it's never going to happen. So I think that was, something, so if you have a goal, if you have a wish, just go for it. I think that was the cancellation of that.
One thing people would be surprised to learn about you.
So I think we kind of touched upon this, but when I was growing up, I used to go to our local Arsenal center because it was at the end of the street, and I used to play football there. And one day, one of the coaches said, play with the older kids and let's see what you've got. And unfortunately, I broke my collarbone that day, and that was the end of my football career. So if that had not happened, maybe I would have been playing football instead of talking here with you today. So that's something people probably don't.
Never know where life will take you.
Absolutely.
Most inspiring person you have met in oncology?
So I think many of my patients inspire me, I have to say. And one of the most inspiring patients that I've had is somebody who survived 4 different cancers. So she had breast cancer, she had ovarian cancer, she had lung cancer, and she also had thyroid cancer, and managed to survive. And not only did she not survive, she still always, whenever she comes to see me, is in very good grace and very funny, and her mood is always very positive. So I think that one cancer can be a very traumatic and life-changing experience, and the fact that she's had 4 cancers, managed to fight them all, and is still very positive in her outlook towards life is just something amazing.
That's so lovely. And my last question for today, if a biography were written about your life, what would the title be?
I think I would say A Novel Path with Risks.
Thank you, Dr. Ghosh, very much for the talk. It was really inspiring talking with you. I hope we'll reach to a point where all of your students and all of your fellows are successful in their home country or in their clinic and continuing your job. I think that would be the best payment you will ever get. And thank you so much for the work you are doing. And thank you for accepting my invitation to be my guest today. Thank you so much.
Thanks so much, Vaya. And I agree that would be the biggest reward I could get if my trainees and fellows are able to learn and give the optimal care to their patients and their institutions. And also, if they can just be inspired to maybe take the field forward as well. And I would be extremely satisfied with whatever I've managed to do in medicine.
Yeah, absolutely. And to the people who are watching us, thank you for being with us. If you like this episode, share, subscribe to our channel, and keep the coffee brewing. Until the next time, bye-bye.